morning. So some of my objectives, I'm going to just briefly review the anatomy and physiology of the pericardium, and then talk about the role of echo in pericarditis, as well as some of those features in constrictive pericarditis, as well as cardiac tamponade. So these are the main guidelines I have referenced throughout my presentation. Just want to point them out because I found them super useful. So the 2025 most recent guidelines on myocarditis and pericarditis, obviously I really just focused on the pericarditis piece today, as well as the ASE recommendations for the specific echo features for the same. Those are from 2013. So we'll touch on the anatomy of the pericardium. So really the pericardium is double layered. We can see it fairly clearly in the picture here. The outermost layer is formed by this sort of fibrous envelope made mostly of collagen fibers. And then it's really continuous to the adventitia as well as to the central tendon of the diaphragm. It's not pictured here in this image. And then posteriorly, it's related to the bronchi, the esophagus, as well as the thoracic descending aorta. The inner layer of the pericardium is composed of visceral and parietal layers, and the space between these inner layers is the cavity that we know of and normally contains a physiologic small amount of fluid, less than 50 milliliters. It serves as a lubricant between the visceral and the parietal layers. The fluid itself normally is drained by the lymphatic system and the pericardionephric veins. The visceral layer covers the epicardium, where there's a variable amount of fat that we can often see on echo as well. And the thinnest segments of the pericardium I found ranged between 0.7 to 1.2 millimeters. That was with measuring by CT, and 1.2 to 1.7 when measured by CMR. The discrepancy, I think, can at least partially be explained by including small amounts of physiologic pericardial fluid in the measured thickness itself. Here's a table from the ASE, just looking at the kind of the functions of the pericardium. It's not essential for life, but it does perform some important anatomic functions. So it provides mechanical protection. It also partitions the heart from the pulmonary space, so less chance of contiguous infections from the lungs. Both pericardial layers also help limit the distension of the cardiac chamber. So if there's ever fluid overload, prevents the heart from essentially deforming the cardiac chambers, as well as the tricuspid, the mitral apparatus, which can, as much as possible, help prevent regurgitation. And so on. The pericardium also facilitates essentially interaction and coupling of the ventricles and the atria. As you can imagine, the RA and the RV are more subject to the influence of changes in the pericardial pressure than the LV, which is more thick-walled, which we'll touch on a lot throughout the presentation. And then it also works as an anti-inflammatory, fibrinolytic, has paracrine function, antigen presentation to the immune system, and so on. And then we will come back to the physiology of the pericardium kind of in future slides. So kind of briefly, I want to go through pericarditis. This is only a part of a really great image from the ESC 2025 guidelines on pericarditis. It's the latest guideline we have, so recommend taking a look if you haven't yet. Briefly, it's inflammation of the pericardium. There's a long list of causes kind of pictured here, from infection-related, autoimmune related, malignancy related. So, most common still being viral infection and idiopathic. Majority of these cases are self-limited, and patients who have symptoms for less than 4 weeks, they determine as acute. More than 3 months is considered chronic, and in between subacute range. According to the ESC guidelines, but as you all probably know, first-line imaging of assessment of pericarditis is echo. So it's a low cost, widely available, really can be performed on an urgent basis if needed. Sorry, my gifts are kind of playing choppily today. But acute pericarditis, some patients may have a totally normal appearing echo. This actually I found between 40 and 50% of cases when it's in the first episodes. And the findings that you can see are increased pericardial brightness and thickening. You can also see abnormal septal bounce, which could suggest early constriction, but that wouldn't necessarily be on first episodes, but in the future. You can also have intrapericardial fiber stands that are very nicely pictured here, suggesting either an inflammatory etiology of the pericarditis itself or clotted blood. And you can also find intrapericardial masses that can be seen with primary or secondary tumors or with inflammatory processes. And then, of course, the main finding you're going to have is pericardial effusion. That can be trivial up to large, can be localized, circumferential, loculated. And importantly, tamponade physiology, you can see it in up to about 3% of patients. Echo can also be really helpful to at least somewhat differentiate acute pericarditis from myocardial ischemia by excluding wall motion abnormalities, even though there are a small percentage of patients with acute pericarditis, about 5%, who will demonstrate segmental wall motion abnormalities. But it's an important indication because, as we know, not infrequently these patients will get referred for coronary angiogram for suspected STEMI because of the ECG changes. Just briefly, I want to kind of touch on role of multimodality imaging. The focus will be echo, but briefly, CT with contrast can be very helpful to make an etiologic diagnosis in patients if they're coming in with large pericardial effusion, maybe tamponade. And it is also very important prior to pericardiectomy because, so for example, in the setting of constriction, to evaluate the anatomy and the extent of calcifications, because it actually has been shown that a higher burden of pericardial calcification is associated with better post-surgical outcomes. CMR can also better differentiate myocardial tissue and shows inflammation and pericardial and myocardial inflammation and different various patterns of fibrosis. So I would say consider doing either CT or CMR if you have inconclusive echo findings, if they're failing to respond to anti-inflammatory therapy, more of an atypical clinical presentation, suspicion of MI or neoplasm or infection, as well as associated trauma and suspicion of constriction. You can use kind of these if other entities need to be excluded, such as metastatic disease. So in patients with malignancy and suspected metastatic disease to the pericardium, you might see a smooth enhancing pericardium with very small effusions that would initially suggest just a non-malignant pericarditis, but diffuse tumor infiltration is also a possibility here, and so a CT or a PET might be indicated. And then in recurrent pericarditis, serial CMR exams can be used to follow pericardial inflammation during the treatment course to guide therapy. But this isn't really grounded in evidence. You'd need further studies to verify the actual benefits of this approach. So what does the guidelines from ESC say? So there's a class 1 indication for CT, as we discussed, for thickness, calcification, masses, loculated effusion, and in the presence of any really like pleural or pulmonary abnormalities. Again, a class 1 indication for CMR, if suspecting pericarditis, to look for edema, late gadolinium enhancement, assess as well persistence of disease and recurrent pericarditis for follow-up. PET and PET-CT are really more of a class 2 indication if you're considering myocarditis, if the CMR and or echo are inconclusive. And it's not pictured here, but in clinical practice, we rarely use pericardial biopsy, really only in complicated cases that aren't responding to the conventional anti-inflammatory therapy, and if there's a high suspicion of a very specific etiology, like primary pericardial tumors, which you can't identify from non-invasive means. So moving on to pericardial effusion and tamponade. So the effusion itself is just an accumulation of fluid in the pericardial space, the cavity, as we talked about earlier. Physiologically, you can have up to 50 milliliters, and that'd be entirely normal. There's tons of causes. Often they will overlap with your actual pericarditis causes as well, but I've highlighted especially post-cardiac surgery and trauma. In terms of the sizes, small is less than a centimeter in diastole. Roughly, this corresponds, I found, to less than 100 mils. Moderate is 1 to 2, 100 to 500 mils, large being more than 2 centimeters, and this usually is more than 500 mils, and very large is more than 2.5, and that's over 700. And notably, these are all measured in diastole. I've heard sort of trace being described as when you can really only see the effusion in systole when the heart is contracting and therefore at its smallest, but I couldn't necessarily find a very specific measurement for that. Something I just wanted to highlight is that the size of the effusion does not correlate with its physiologic effects that it might exert. Hopefully the images play not too poorly, but I just want to go through some of the fundamentals of looking at pericardial effusion on echo for maybe some of the more juniors here as well. So first off with landmarking. So, on your peristernal long axis, which is this view here, you're going to find your descending aorta. Fluid that's below that is always a pleural effusion, whether that's left or right sided. Here it's only the left. And then above that is going to be your pericardial effusion. Here is very, very trace. And then this is also a nice parasternal long axis, but you can see a significant more amount of pericardial effusion here, and a little bit kind of posterior to the RV as well. This is your short axis view. So on this view, you can see a nice effusion, particularly behind the LV. On your bottom left, you have an apical, shows all 4 chambers and their valves nicely. And you can see, again, the same effusion demonstrated behind the LV. And on the subcostal, which is just your apical kind of flipped onto a horizontal view, it's where you can see the extent of the effusion the best, behind the RV. You really couldn't see it as well on the other views, but when you kind of open it up to the subcostal, you see it the best here. And the importance of looking at all the views on echo, of course, is to get an idea of how large your effusion is, whether it's circumferential, whether it's localized, but also where the best possible access point would be for pericardial tap, commonly being subcostal or apical. So let's talk a little bit about pericardial effusion or physiology. We'll come back to these concepts a lot when talking about tamponade. These images are directly from the ASE recommendations on pericardial disease. So you have a pressure volume curve here, pressure being on the y-axis, volume being on the x. And we're just going to focus first on this curve here. As you increase the volume in the pericardium, overall you're seeing the pressure is rising. In a rapidly increasing effusion, the fluid first reaches the limit of the pericardial reserve volume, which is kind of this initial flat segment here, very quickly, and then exceeds the limit of the pericardial stretch, indicated by the dotted line, which causes just a steep rise in pressure, and it becomes even steeper as just smaller increments in fluid are causing a disproportionate increase in pericardial pressure. And then here on the right, you have a slower rate of pericardial filling, so that flat segment is much longer, and it takes longer to exceed to that limit of pericardial stretch because there's more time for the pericardium to stretch and for compensatory mechanisms to become activated. But once you exceed the limit of the pericardial stretch, again, you're getting into tamponade physiology, so chamber collapse, hemodynamic compromise, and it all limits cardiac output. So I think we can clearly see that for rapid effusion, that it doesn't take much volume before that happens, whereas a slow-growing effusion, you can accommodate a lot more. And so again, it's important because don't be fooled into seeing a small effusion and thinking that it can't have tamponade effects, because it's all based on how fast it's grown and the clinical context. Again, a really important concept of ventricular interdependence really just lays the foundation for a lot of the echo findings that we do see. So just focus on kind of this photo here. You have the LV and the RV separated by an intraventricular septum. As you take a breath in, you're lowering your diaphragm, you're creating negative intrathoracic pressure, and that creates a vacuum that allows increased venous return into the RA, and then the RV subsequently gets bigger. And under normal circumstances, you do get a bit of the intraventricular septum shift, but the LV can still accommodate well. There's no hemodynamically significant change to your cardiac output. You can get a minimal physiologic drop in blood pressure with inspiration that's less than 10 millimeters of mercury of a change. And then the opposite happens with expiration, where your LV is able to expand, but as a result, your intraventricular septum shifts towards the RV itself. But again, it's all within normal range on a day-to-day basis. But I think the concept here is that filling of one chamber happens at the expense of the other. And this is an M mode showing kind of a similar concept but in the presence of a pericardial effusion. And just quickly for those who are less comfortable with that, it's basically just a cross-section of the parasternal long axis that you're seeing here. And you're going through all of the layers and is showing it over time. So initially you're starting off really with just kind of your chest wall, then your pericardial effusion, your RV wall here, the RV cavity, the intraventricular septum, the LV cavity, the LV free wall, and then some more pericardial effusion here. So that's kind of all of the layers that you're seeing on M mode. And this image shows the same concept of ventricular interdependence, but more exaggerated and non-physiologic because of the presence of a pericardial effusion. So the RV is now not able to expand at all due to the effusion compressing on it. So the only way for it to accommodate the increased venous return in inspiration, which is pictured here, is by shifting the intraventricular septum down towards the LV loops. And it's subtle, but it is there if you're comparing kind of here in expiration versus here in inspiration. And then you can see now the septum shifting more towards the LV during the RV during expiration to allow increased filling of the LV as well. So again, exaggerated response due to the effusion. And this is where the concept of pulsus paradoxus comes in, where you have a systolic blood pressure drop of at least 10 millimeters of mercury with. So, what is tamponade? I think we're all familiar, life-threatening condition caused by fluid accumulation. It's compressing the cardiac chambers, inhibits normal filling. In its very advanced stage, it's characterized by equalization and elevation of the cardiac diastolic and pericardial pressures, causes reduced cardiac output, and an exaggerated inspiratory decrease in systolic blood pressure known as pulsus. Fundamentally, though, it is a clinical diagnosis. Of course, you'll hear a lot of talk of echocardiographic signs of tamponade, which are important and play into your decision making. But ultimately, it's a clinical diagnosis, not a radiographic diagnosis. It's a cause of PEA arrest, so something to keep in mind. One of the H's and T's if you're ever running a code blue with a PEA arrest. I think we all know Beck's triad, so I won't press on it too much, but just as an interesting historical point, it was Claude Beck, a surgeon, who was the first to describe and publish this concept. But he actually had two Beck's triads. We really only hear of the one, is the acute triad. So he called it acute cardiac compression triad. It's tamponade, essentially, which is jugular venous distension, hypotension, and muffled heart sounds. But he has a second triad that I think is less commonly talked about, and we'll come back to that a bit later. This is a list of all of the echocardiographic signs of tamponade. Lots of signs. The more you have, the more the likelihood that you have tamponade. Some are just 2D or M mode diagnoses, just like swinging of the heart, the effusion itself, collapse of the chambers, IVC. But some are more Doppler related, which we'll touch on kind of all of these. So let's talk about kind of RA collapse. Starts at the end of ventricular diastole, kind of into systole. Both chambers are collapsing during their relaxation phase when the intracavitary pressure reaches the lowest value and will transiently fall below the pericardial pressure. For the atria, the inversion starts kind of near the peak of the R wave. For the ventricles, it more so occurs in early diastole after the end of the T wave. The right atrium will stay inverted. Sorry that the images aren't playing super smoothly, but it stays kind of inverted until filling during ventricular systole increases its pressure above the pericardial space pressure. And because the RA is such a thin-walled structure, you can actually see some brief inversion of the RA in the absence of tamponade itself, which is why it's important to actually look at the duration of RA inversion or collapse if you're suspecting tamponade. So if it exceeds a third of the cardiac cycle, that's nearly 100% specific and sensitive for clinical tamponade. Hopefully you can somewhat appreciate the buckling that's in this image. In terms of RV collapse, early diastolic collapse of the RV also essentially signifies that the pericardial pressure is exceeding the RV pressure. I like this image because it times it well in terms of when diastole is, so you can actually see it, but kind of poorly demonstrated on the GIF. So RV diastolic collapse, generally it occurs with moderate elevations in pericardial pressures when the cardiac output has decreased by about 20%, but systemic blood pressure hasn't yet fallen. And collapse is worse during expiration, which just makes sense, right? Which is, during inspiration, we're getting increased blood flow and venous return and some expansion. So it makes sense that it's at its worst during expiration. But then as tamponade gets more severe, you can see it throughout the respiratory cycle. I've shown this picture before, but you can see during expiration how the RV chamber size gets significantly smaller compared to during expiration, and then opposite during inspiration. The RV free wall also stays indented until the chamber pressure with diastolic filling will exceeds pericardial pressure. So again, the longer the duration of compression, the worse or severe the effects of tamponade. There's been some experimental studies showing that the right heart chamber collapse occurs earlier than pulsus paradoxus, and the sensitivity and specificity of chamber collapse improves as the severity of tamponade increases. The one kind of small caveat to both RV-RA collapse is posterior loculated effusions during cardiac surgery. You might be getting more LA-LV chamber collapse, but we'll get back to that. This is my own video from a case I saw at Western. Obviously, pretty remarkable kind of swinging heart here. And I just wanted to touch on this because, it's interesting that this phenomenon is what gives you electrical cardinals. So you can see the sort of QRS changes in voltages as the heart is swinging because of the voltages here. So as we talked about with inspiration, you have less cardiac output. So when we are looking through the mitral valve, we can measure something called the peak E wave velocity. Essentially measures the speed of early rapid blood flow from the LA into the LV during diastole. You get lower E wave velocities with inspiration, again, because of kind of the physiologic effects we talked about. And under normal circumstances, the change in the peak E wave velocity might be, 5%, no more than that. With tamponade, you have to have a reduction of at least 25%. ASE actually says 30% to really meet that definition. Conversely, with the tricuspid valve, during expiration is when you get reduced flow through that valve. But there's more variability at baseline with the tricuspid valve. I'm not actually entirely sure why that is. So the threshold to meet tamponade with the tricuspid valve E velocity, we say is at least 40%, but again, ASE says actually 60% variation. Here are some of the images showing pulse wave Dopplers, first the mitral and then the tricuspid, and then the corresponding respirometer here, so you can see when inspiration is and expiration. So on the left, mitral valve E velocities, you can see that they're the lowest during inspiration, and ASE suggests that you should be looking at the first beat during the expiration and the inspiration phase when you kind of pick which wave to focus on. And you can see that they're the lowest during inspiration. And on the echo machine, you can actually quantify what the exact number is. And you'll do the same with inspiration as well. And the formula is expiration minus inspiration over expiration to look at the change. The first beat, as I said, that happens is when you want to see the lowest velocity, and then the first beat that happens with expiration is going to have the highest. Similarly, for the tricuspid valve on the right, except the E velocities here are the opposite, so they're higher with inspiration, which is kind of this wave. So you can be looking at this beat as the first beat during that, and then with expiration they go down. So you can see a remarkable sort of change here. And if this change is more than that 40 to 60% range, then that's consistent with tamponade physiology. So LVOT respiratory variation, you can do something pretty similar with this. It's actually basically the manifestation of pulses on echo. So you can get a drop with inspiration, again, looking at the respirometer, looking at inspiration, sort of the first or so beat, remarkable change compared to expiration. It's kind of nice and easy to remember because it's about the change is 10% that you want to focus on, which is the same as pulses. So IVC plethora, highly sensitive but not super specific for tamponade, as there's lots of conditions that can cause IVC dilation, as we all know. If the IVC is small and collapsing, you should revisit the cause of the patient's shock state, since typically with cardiac tamponade, you'll have high right-sided pressures and should have IVC dilation. There are caveats to this. For example, in the setting of localized effusions, like post-cardiac surgery, if the effusion is more on the LV side, you might not get that right-sided compression that would cause dilated IVC. Here you can see a very clear IVC dilation, even the hepatic veins look dilated. And then you throw an M mode across, so again, a cross-section of what you're seeing here over time. And they have provided the numbers here for you, 21 versus 24, but even visually you can see that there's not much variation across time. Just some unique sort of tamponade entities. The reason that I just wanted to bring these up is because they don't have the classic findings of tamponade necessarily, so they can be maybe a little bit easier to miss. Low pressure tamponade is basically a form of tamponade where you have relatively low pericardial pressures, which is opposite to what you usually see in tamponade, but you have cardiac compression anyways because of the low filling pressures inside the chambers. It's hard to diagnose because there's a dramatic kind of loss of sensitivity of the classical findings like dyspnea, tachycardia, hypotension, elevated CVP. But basically, the concept is that when you gradually develop a pericardial effusion, you'll tend to compensate by retaining volume, so your CVP will rise, and they may never actually develop this low pressure tamponade. But you can get it in the following situations, which is when you have rapid accumulation of the fluid, like a acute hemorrhagic pericardial effusion, or subacute pericardial effusion, but acute volume loss, so GI bleed, diuresis, dialysis, and so on. And the diagnosis of this is pretty similar to what we see with other patients, but recognizing that you might not have elevated CVP, the IVC might not be dilated, pulses might be absent, and then on history, that clinical precipitant of gastroenteritis, for example, or whatever the condition might be, causing low intracavitary pressures. And then the step that you want to focus on, am I drawing on the Zoom?
No.
Okay. The step that you want to focus on is volume resuscitation. In pulmonary hypertension, kind of the second entity I've noted here, because the right-sided pressures are already high at baseline, patients can be in tamponade, but you might not have RV collapse or RA collapse since the pressures inside the chambers are already so high. We talked about the post-CV surgery kind of localized effusions already, where because it's more localized, you're not getting the clinical findings depending on where it is. So moving on a little bit to constrictive pericarditis. So briefly, constrictive pericarditis, it's a thickened, with the caveat, scarred, inelastic, and often very, calcified, non-compliant pericardium, and it limits the diastolic filling of the ventricles. The etiologies of constrictive pericarditis are very diverse: viral recurrent pericarditis, cardiac surgery, collagen disease, radiation, and sometimes idiopathic. They did this study somewhat recently, or I guess not super recently, but they essentially compared the causes of constrictive pericarditis between the period of 1936 and 1982, as well as 85 and 95. The major change is that cardiac surgery is now the most common known cause of constriction. Idiopathic is still kind of the winner, but in terms of known causes, cardiac surgery now in developed countries. Diagnosis of this, again, very multimodal. Echo is helpful. We're going to talk about some of the findings, and you can almost reasonably come to a good conclusion of whether to rule in or rule out constrictive pericarditis based on echo, and we'll talk about the criteria. But you can also do right heart cath as well as CT imaging. The pericardium becomes thickened in most but not all cases, and I just wanted to kind of point out this interesting study. It's basically a study done in 2003. It measured pericardial thickness in patients with surgically confirmed constrictive pericarditis. So it was based on a surgical exploration. They found that the thickness was normal in about 18% of cases. So it's not so much, the focus isn't about it being thickened, but stiff and inelastic that causes this phenomenon. So normal pericardial thickness does not rule out constrictive pericarditis. So I think I told you guys about a second triad that Claude Beck described. His second triad is called the chronic cardiac compression triad. And basically, while the first one was acute for tamponade, the second is for chronic constrictive pericarditis. His second triad is still the same in terms of high venous pressure, small, quiet heart. But the most important thing is instead of hypotension, you have now ascites. The key difference is basically comes down to the timeline. So unlike the acute shock of tamponade, constriction is a very slow, chronic process. So the patient's usually able to maintain their blood pressure, but the long-standing venous congestion eventually will lead to ascites, which we can often see in constrictive pericarditis. Again, basically a very stiff pericardium. It prevents the cardiac chambers from seeing the outside pressure changes in the thoracic cavity. So during inspiration, as we talked about, normally intrathoracic pressure drops. This is reflected in the cardiac chambers exactly as tamponade. And in constrictive pericarditis as well, the RV is going to fill at the expense of the LV and vice versa with expiration. Right-sided flow velocities will increase with inspiration. Left-sided flow velocities increase with expiration. And this is an echo kind of image. It's not a GIF, it's just a still image showing respiratory variation in the septum. So you can see the septum here has kind of moved or bowed into the RV as a result of expiration, and then vice versa, bowing into the LV as a result of inspiration. And these signs, again, are consistent with ventricular interdependence. This is the M mode, as we talked about before. This is the RV cavity space. This is the LV cavity space. During the peak of inspiration marked by this arrow here, the septum has moved down towards the LV to accommodate for the RV's increased venous return. And the LV cavity is really at its smallest here because of that bowing of the septum. And then in the peak of expiration, kind of off the slide here, but essentially where the arrow is pointing, the RV cavity is at its smallest because the septum has now bowed towards it to accommodate for increased LV filling. This is a really interesting and important concept, this kind of tissue Doppler and constriction. The concept is called annulus reversus, which is seen in constrictive physiology. That's a differentiator from tamponade, but also from restrictive cardiomyopathy. What we're seeing here is the tissue Doppler. So again, for just as an indicator for those who might not know, normally the lateral or the free walls of the RV and the LV can move much more freely than the medial wall or the septal wall. So lateral E prime is greater than medial E prime in the normal setting. However, with constriction, the free walls of both the LV and the RV are tethered down by this very stiff pericardium. So they're unable to move because of how stiff it is. And then the lateral E prime shown here is much lower than the medial E prime shown on the left. And this concept is called annulus reversus. So similar, this diagram essentially just shows what the Mayo Clinic published as the echocardiographic signs or the criteria of constrictive pericarditis. And I think with this, you can come to a reasonable conclusion based on just echo alone, whether or not you have constriction. So you start off having IVC plethoric, not a very specific sign, but then you have to go to the mitral E over A being at least 0.8%. If you don't have either of those, constriction is unlikely at this point. Then you are going on to have ventricular septal shift with respiration, as we talked about, plus another one of these echo signs of either annulus reversus or hepatic vein diastolic reversal with expiration. At that point, if you've got one or two of those signs, you can be pretty certain that you have constrictive. Probable if it's just one, and it's confirmed if you've got both of those signs. I really like this image. I hope it plays reasonably well. I actually got it off of the St. Mike's Echo YouTube channel. So it's a concept really about how to differentiate the constrictive pericarditis versus restrictive cardiomyopathy. First of all, as we talked about, constrictive pericarditis, totally a pericardial disease. The actual muscle or the myocardium is normal. Restrictive cardiomyopathy is a myocardial disease where the myocardium is completely stiffened, but the pericardium is fine. And tissue Doppler is very, very helpful to differentiate the two. Restriction overall is characterized by low tissue Dopplers all around because the myocardium is affected. In pure constrictive physiology here, you can see the myocardium is normal, but you have a thickened pericardium, so it can only move longitudinally. So the relaxation of the heart doesn't go sideways, but more longitudinal, making the tissue Doppler like the square is coming out of the box, essentially. It's very enhanced tissue Dopplers, and this applies specifically to the medial E prime, not the lateral. And since that's what's not tethered down by that stiff pericardium. Whereas in the restrictive here, the tissue Dopplers are just very low overall because the myocardium, really anywhere, but we're focusing on the medial aspect here, is so stiff. And then in the normal heart, you have the medial being lower than the lateral E prime. So I hope that's helpful. And then there's a few other pericardial entities I didn't touch on too much, but I just wanted to bring them up just to make you aware that they exist. So effusive constrictive pericarditis, it's the least common kind of the pericardial syndromes that we have. And it's defined as this persistence of elevated intracardiac pressures, even after pericardiocentesis for tamponade. So your initial presenting hemodynamics look like tamponade. You'll drain the pericardial fluid, but you have a reduction in pericardial pressures, which is what you expect to see, but there's still persistence of diastolic filling abnormalities within the cardiac chambers. So at this point, you've basically transitioned from tamponade physiology to that of constrictive pericarditis. So it's like a retrospective diagnosis after the TAP. And then they also in the ASE guidelines touch on congenital absence of pericardium and pericardial cysts, but I didn't get into that too much. So just to kind of round off some of the takeaway points here, though tamponade is a clinical diagnosis, echo can obviously provide clearly a lot of supportive factors that can help with that decision making. The size of the effusion does not correlate with its hemodynamic effects, but there are some types of tamponade that might not have the usual clinical or echocardiographic findings. So like low pressure tamponade, localized effusions. And then dilated and non-collapsible IVC has a very high negative predictive value for tamponade, but be aware of some of the caveats we talked about. And then all patients with clinically suspected constrictive pericarditis should undergo an echo with Doppler specifically as the initial imaging test that can really provide a pretty good definitive diagnosis in probably most patients. Some of my references, and that's all.